Hello everyone. Today the topic that we'll be talking about is trigeminal neuralgia. So trigeminal is the fifth cranial nerve and neuralgia means an intense intermittent pain along the course of a nerve. So trigeminal neuralgia, International Headache Society, can be defined as a unilateral disorder which is characterized by brief electric shock-like pain which may be abrupt in onset and termination, and it may be limited to one or more divisions of the trigeminal nerve. Most commonly, it affects the maxillary branch and the mandibular branch. It usually affects the older population, which are above 50 years of age, and women are most commonly affected as compared to men. There is a 1.5:1 ratio. Now, trigeminal neuralgia can be classified. The first subtype is the classical trigeminal neuralgia. It occurs due to the compression of a nerve, and this compression may be due to a blood vessel pressing against the nerve. The second type is the secondary or the symptomatic trigeminal neuralgia. This occurs due to either multiple sclerosis or again the compression of a nerve by either a tumor or an arteriovenous malformation. Then we have the idiopathic trigeminal neuralgia. We are not sure what exactly causes this kind of trigeminal neuralgia. Now, to understand the disease process for the trigeminal neuralgia, first we will have to go through the anatomy of the trigeminal nerve. So, as we know, the trigeminal nerve is the fifth cranial nerve and it originates from the pons. It is divided into three branches. We have the ophthalmic branch, then we have the maxillary branch, and we have the mandibular branch. The mandibular branch can be further divided into the lingual nerve and the inferior alveolar nerve. We also need to know that there is a trigeminal ganglion which is located in the Meckel's cave. This trigeminal ganglion consists of cell bodies of the sensory root of the trigeminal nerve. Now, to understand the disease process, first of all, there will be a neural pathology which may occur at the root entry zone. Over here is the picture of the brainstem, and we can see that the trigeminal nerve is emerging from the pons. So right here is the root entry zone, and a compression due to a blood vessel or a tumor may compress this area and cause a neural pathology. Also in this zone, there is a transition of the peripheral Schwann cell myelination to the central oligodendrocyte myelination. This change in the cell type makes this entry zone particularly susceptible to pressure. Now, what happens next is that demyelination and remyelination starts to occur, and this occurs due to microvascular ischemic changes, meaning that there is a compression of the blood vessel, the blood flow is obstructed. So ischemia is going to occur. This causes excitability of the threshold of the affected fibers to be decreased. Now, this promotes an inappropriate communication of impulses through the fibers. Next, the tactile signals from the fast myelinated alpha beta fibers activate the slow alpha delta fibers. This results in high frequency paroxysms, meaning a high frequency of excitability of all the neurons and the nerve fibers. So that characterizes the trigeminal neuralgia. After this, there's going to be a period known as the refractory period, and in this, the stimulus, no other stimulus, will be able to trigger a pain. Now, this refractory period is very important in differentiating trigeminal neuralgia with other kind of pain disorders. Now, let's talk about the clinical features. In the early stage of the trigeminal neuralgia, the pain may be mild, dull aching, or even burning sensation-like. This leads to a misdiagnosis of the trigeminal neuralgia. Now, as the disease progresses, the attacks are going to become more frequent and the pain is going to increase in intensity. Some people describe the pain to be like a bolt of lightning. Others also say that it feels like that you're being stabbed by an ice pick. And some other patients say that it feels like an electric shock. Now, the pain is provoked by a stimulation of the trigger zone. There are specific trigger zones on our facial area in the distribution of the trigeminal nerve. Number one is the nasolabial area. Other areas are upper and lower lip, chin, cheek, and sometimes the alveolar gingiva. Now, the pain usually lasts from a split second for up to 2 minutes. And after this, the refractory period comes in, meaning that in this refractory period, no stimulation of the trigger zone will elicit another attack. A stimulus may be washing the face, shaving, eating, brushing your teeth, or even a simple breeze may start an episode of trigeminal neuralgic pain. Usually one side of the face is involved. Bilateral involvement usually suggests multiple sclerosis. Now, what is multiple sclerosis? So, multiple sclerosis occurs when the immune system attacks the body's own cells. The protective myelin sheath, which is covering the nerve fiber, is going to be attacked and damaged. This causes communication problems between the brain and the rest of the body. Did you know that the trigeminal neuralgia may be one of the early symptoms in multiple sclerosis? Next, we'll be moving on to a criteria which is going to help us diagnose the trigeminal neuralgia. The International Classification of Headache Disorders have created a diagnostic criteria for the trigeminal neuralgia. They say that the recurrent paroxysms of the unilateral facial pain in the distribution or one or more of the trigeminal nerve should not radiate beyond a point, and it must fulfill a specific criteria. That is as follows, that the pain, it should last from around a fraction of a second to 2 minutes. It must be severe in intensity. It has to be an electric shock like shooting sharp pain, and it also states that it must be precipitated by an innocuous stimuli. And lastly, it should not better account for any other headache disorder. Now, if you would like to read the article in much more detail, I've shared the link below. Now, let's compare trigeminal neuralgia with temporal arteritis. Trigeminal neuralgia is caused by the compression of the trigeminal nerve, whereas the temporal arteritis is due to an inflammation of the temporal artery. The pain site for the trigeminal neuralgia is on the face along the affected branches of the trigeminal nerve. For the temporal arteritis, the pain site is the temporal region. The pain in the trigeminal neuralgia is a very sharp electric shock-like pain, and it is unilateral, whereas the pain in the temporal arteritis is usually a headache, facial pain, or visual pain or visual disturbances. Now, how to diagnose a patient with trigeminal neuralgia? First of all, we need to take a detailed history of the patient. We need to ask the patient about the type of pain, trigger zones, and the duration of the pain. We can also carry out MRI, magnetic resonance imaging, and we can check for tumors and multiple sclerosis. If the patient has multiple sclerosis, we will see lesions in the white matter of the brain just near the ventricles. I've shared a picture of an MRI, and over here the red arrows are showing that there are lesions in the white matter. Also, we need to rule out any other dental cause, and sometimes we can also diagnose trigeminal neuralgia by prescribing the patient carbamazepine for a few days, and if the patient claims that the symptoms have improved, this means that the trigeminal neuralgia diagnosis is confirmed. Now let's move on to the treatment options. Surgical methods for treating trigeminal neuralgia can be divided into 4 groups. First of all, we have the lesions which are distal to the trigeminal ganglion. Then we have the lesions which are at the ganglionic level. We're going to discuss the treatment options in just a few minutes. Whereas there are some lesions which are at the root And for that, the surgical treatment is gamma knife radiosurgery. And we also have a posterior fossa intervention. And for that, we have the microvascular decompression. Now, first of all, we're going to talk about the non-surgical intervention. We are going to prescribe the patient anticonvulsants. These are going to be combined with muscle relaxants. So, carbamazepine 200 mg is initially prescribed, which may be increased up to 600 mg. And along with this, we prescribe the patient a baclofen, which is a muscle relaxant. A combination of this helps to ease the pain. Now, to memorize their adverse effects, there are 5 Ds. So, number 1 is that the dose has to be increased over time because the medication becomes less effective. Then we have drowsiness, dry mouth, diarrhea or nausea, and there is also a decrease in the white blood cells, which is also known as leukopenia. So guys, just remember your 5 Ds. Next is the surgical techniques. We'll talk about the suboccipital microvascular decompression. So access is taken from the occipital bone just behind the ear, and a sponge-like material is placed between the nerve and the blood vessel. This is going to prevent the blood vessel from returning to its original position and causing a compression on the nerve. Around 65 to 73% of the patients are pain-free for around 10 years. Some of the adverse effects include facial numbness and ipsilateral hearing loss, meaning one-sided hearing loss. Now, for the peripheral lesions of the trigeminal terminal nerves, we have the following procedures. Number 1 is the cryotherapy. In cryotherapy, localized freezing temperatures are used. Liquid nitrogen is the choice, and it is used to target the irritated nerve. Some of the adverse effects include pain, crusting, scarring, and reduced efficacy of the procedure. Then we have the radiofrequency thrombocoagulation rhizotomy. High frequency heat is targeted to the area of the trigeminal nerve, destroying its ability to transmit the pain signals to the brain. Its adverse effects include anesthesia dolorosa. Anesthesia dolorosa is a combination of anesthesia with spontaneous pain. And also, this procedure is not very efficient, so it has to be repeated many times. Next is the neurectomy, meaning the peripheral branches of the trigeminal nerve are cut off. This is the simplest and the most safest procedure that is there. The adverse effects include facial swelling and bruising at the site of entry. Next, we have the alcohol injection. So basically, just like an anesthesia during the procedure is given, we use alcohol block injection. And this is a minimally invasive procedure. But there are some adverse effects. These include local edema, high risk of recurrent pain, and necrosis of the surrounding tissues. And lastly, we have the microvascular balloon compression. We use a specially designed 14-gauge needle. This is passed through the foramen ovale. Over here, I've attached the picture of the base of the skull. We can see that the needle is going through the foramen ovale. The entry point that is taken is basically 2.5 centimeters lateral to the corner of the mouth. After this, we use the X-ray and insert the balloon catheter through the needle and entering the Meckel's cave where the trigeminal ganglion is located. The balloon is then inflated. The duration of inflation depends on the duration of disease. So, longer the course of the disease, longer time that we will be inflating the balloon. Its adverse effects include that the procedure may need to be repeated. Anesthesia dolorosa might take place, and facial dysesthesia. Facial dysesthesia is basically a distorted sensation of the facial skin. So guys, this was everything about trigeminal neuralgia. I hope you enjoyed.